following podcast is part of a certified educational activity titled Realizing Improved Outcomes in HER2-Positive Gastrointestinal Cancers, New Evidence and Practical Guidance with Targeted Agents. Access the entire activity and complete the post-test at peerreview.com/NEB860. Downloadable slides and practice aids are also available.
Hello, welcome. It is my pleasure to be here today to discuss about a hot topic not only in gastric cancer but also colorectal cancer, that is the role of HER2 overexpressed tumors. So we are really honored to welcome in Barcelona Dr. Elena Janjigian. I have pronounced it well.
Thank you. Yes, perfect.
Focusing on colorectal cancer, it is true, as I mentioned before, that it is not included the determination of the HER2 status in all guidelines, although it is in the NCCN guidelines. But there is a proportion of patients that do present, whose tumor present an overexpression of HER2. So in certain cases, it has been correlated with a worse prognosis, and its predictor effect regarding the anti-EGFR treatment strategies has been a matter of discussion until recently. In the case of gastric cancer, and Yelena, later on you can tell us if you agree with these results coming from a real-world data study. In this study, it was published that nearly more than 30% of patients were not determined for the HER2 status when they were diagnosed for gastric cancer, and an important proportion of patients did not receive a frontline treatment with HER2 targeted therapy, and a similar situation in the later on treatment. So it is quite intriguing, and I think it's an interesting also matter of discussion. So here we have a European experience focusing on HER2 that we would say that maybe the percentage of the determination is slightly higher. And it seems that for those patients in which the determination is performed, they seem to have better outcomes in terms of overall survival, probably because of the use or the incorporation, the earlier incorporation in the treatment of HER2 targeted therapy. So regarding the approval, we know that equity is also a matter of discussion worldwide, but we know that we have the approval by the FDA for both Trastuzumab and also Trastuzumab deruxtecan, particularly in gastric cancer. And in that sense, for me, it's a pleasure to have in Barcelona Dr. Janjigian to discuss about the role of HER2 overexpressed gastric cancer. Please go ahead.
Thank you so much for the kind introduction. It's such a pleasure to be here in Barcelona again in person and to talk to you about my favorite topic, which is HER2-positive disease. It's really, there's been a lot of activity and data that I can update you on. So in gastric cancer, more so I would say in breast, HER2 positivity is a complicated topic because often it co-occurs with other family members of the HER2 superfamily. So we know EGFR very well, which is HER1, and certainly HER3 and HER4, although studied and underrepresented in gastric cancer, is also a major topic because up to 30% of gastric and esophageal tumors, adenocarcinomas, have HER3 alterations as well. So once we have the activation of MAP kinase pathway downstream, it's very difficult to overcome both primary and acquired resistance to Trastuzumab, and that's why the field in our disease has stalled, because just targeting HER2 more effectively, as was done in breast cancer, has not really helped as much in GI cancers. So in gastric cancer in particular, and we have the gastric story here on the bottom, and based on the TCGA and the TOGA data, and then the breast cancer story here. In gastric cancer in particular, as you see here by these three colors of HER2 3+ overexpression in each particular tumor, there's a lot more heterogeneity. In other words, you'll have a small focus, a cluster of HER2 positive cells, And then in the rest of the cancer biopsy, there's either low expression or indeterminate expression. And in breast cancer, you see a lot more complete staining, strong staining. And so obviously if you have only focal positivity or positivity in a small sample, repeat testing of even the same biopsy sample or different metastatic site may present a different result. And that's what we see in the literature, and we presented this from one of our trials, is that the heterogeneous expression leads to inconclusive testing or discordant testing in the community and between central testing, certainly for clinical trials. So a proportion of tumors that test positive varies depending on where in the GI tract you test. We know that proximal and G-junction tumors and distal esophageal tumors are slightly higher percent of HER2 positivity, and it's up to 30%. We also know, as shown here, that diffuse subset of gastric cancer is almost never HER2 positive. It's only 6% positivity. So, and overall, if you look in the whole spectrum of the disease, it's up to 15 to 20%. You know, often if you talk to our colleagues in South Korea or Japan, because distal gastric cancer is more common there, the positivity rate is closer in the upper teens, 15 to 20%. In my clinic, because I see so much, and probably your clinic, if you practice in the West and Europe, is G-junction esophageal adenocarcinomas are so much more common. And the rate of positivity there is as high as 30%, especially in moderately to intermediately differentiated tumors. So I'm trying to convince you that it's a issue you have to test. I mean, it's, you know, this real world data is quite sobering. And we see it from, for example, from phase 3 Checkmate 649 study, that up to 40% of cases worldwide were HER2 unknown. In other words, they were never tested. Some of it, I think, is access to Trastuzumab, because it's, if in your practice you are not able to get patients HER2-directed therapy, you understand why you wouldn't test them for it. So what about IHC versus FISH? So immunohistochemistry appears to be a stronger, more robust biomarker. There it's a little tricky because obviously you can't assess the level of amplification, right? So what we know is that if you have IHC3 plus positive tumors, close to 95% of those cases will be also FISH positive, right, by fluorescent in situ hybridization. FISH testing takes longer. It takes 3 or 4 days, sometimes a week. IHC can come back quicker, and so IHC is where we typically start. If you have a IHC2 plus FISH negative patient, those typically don't do as well on first-line Trastuzumab at least, and we'll get to the point about ADCs and low-expressing tumors later. So the testing paradigm, at least in my institution, and I would love to hear what you do in your practice, is that we start with immunohistochemistry. The threshold for calling something positive in gastric cancer is a little lower than it in breast cancer. So it can be 5 to 10% a cluster of cells, and we know because of the nature of the gastric epithelium, it can be focal or cytoplasmic staining. And sometimes reading the fine print on the pathology sample helps you understand if the patient, how HER2 positive are they. And having FISH also helps because if you have high level of amplification, the ratio of what we look at the gene and the centromere, if you have high level of HER2 amplification, those patients tend to do better. And you can see here from the TOGA study, the forest plots here, that if you have no amplification and it's a FISH, IHC plus tumor, the benefit is low, and certainly if you have a high expressing tumor, so patients that you and I would consider HER2 positive in the clinical practice, which is IHC3 plus or IHC2 plus FISH positive, the median overall survival to receive Trastuzumab with first-line chemotherapy is 16 months. So, we're very excited now for HER2 negative disease with Checkmate 649, where we passed the 1-year threshold, with nivolumab and chemotherapy. This is 16 months median overall survival for HER2 positive tumors. It's very important to test for HER2 and to understand how likely is your patient to do well. What we also know, and I mentioned this early on, is that intrinsic trastuzumab resistance is a major factor in a G junction and esophageal cancers in particular. Remember, the TCGA told us these are chromosomally unstable tumors. SYN tumors have many amplifications and alterations. And if you have co-occurring amplifications in RAS, PI3 kinase mutation, other activation of MAP kinase signaling, targeting HER2 is not going to really have a durable and meaningful survival. So this is what we showed. We just did NGS on first-line patients who were getting chemotherapy with FOLFOX and trastuzumab in standard practice. We published this in Cancer Discovery several years ago now, and it developed the hazard ratio for benefit for patients. So in gold, you see here, hazard ratio of 0.42 if you have a very high level of amplification by NGS. And remember, if you have a high level of NGS amplification, that means you really are HER2 positive, because you take all the cells in the tumor and extract the DNA. So it's, if you have a high level of amplification, that means there was more cells with amplification in each individual biopsy. So high level of amplification and otherwise wild type RAS, PI3 kinase, and no MET amplification or EGFR, those patients do really well. Their PFS was much more meaningful. If you have HER2 positivity by clinical assessment, but no positivity by NGS, those patients didn't do as well. They're on this purple line, and you see here the hazard ratio is on the wrong side of the forest plot. It's as if they're not HER2 positive. So what we've been doing wrong in GI is that we kept going after the breast cancer paradigm. We kept targeting HER2. We're saying, okay, well, trastuzumab works, let's do trastuzumab and lapatinib, or trastuzumab and pertuzumab. And when you have, alterations that are beyond HER2, just going after HER2 was not sufficient. There are other, inhibitors on the market, and I mentioned the pertuzumab story. Mirvetuximab certainly, has done okay, pretty good in breast, and was looked at briefly and was looking at in gastric. Intracellular targeting with both reversible and irreversible inhibitors had some, activity. Lapatinib failed. Tucatinib is much more specific to HER2 and is now in development, and we're waiting to see some of that data. Initially was promising. ZW25 certainly, the bispecific antibodies, the dual targeting is promising and is under development. And what we're going to talk to today is trastuzumab deruxtecan and some data on TDM1 in gastric cancer. And also this concept of dual anti-PD-1, anti-HER2 therapy, because what we're learning about, both in preclinical and clinical models of gastric and esophageal adenocarcinoma, is that overexpression of PD-L1 is actually a mechanism of resistance to trastuzumab, because it might be that in gastric cancer, trastuzumab works so better because of ADCC activity as opposed to just a HER2 activity. So Checkmate 649 covered the HER2 negative population, right? And it's FDA approved in April of 2021. It's now available in Europe and in pretty much most countries globally. Nivolumab plus chemotherapy improved survival, but HER2 negative patients were mostly in this population, and patients were not allowed to go on the study if they were HER2 positive. We know that in that population, PD-L1 is somewhat predictive, but even in a HER2 negative or unknown population, more than 60% of patients have PD-L1 overexpression. So 60% are CPS5 or greater, 80% are CPS1 or greater, right? So that's that. So Checkmate 649 already changed practice. I was just showing you the median, right, for Traz. Here it's 13.8 months for intent to treat population, 14 months for the biomarker selected population. So what is the evidence supporting use of immunotherapy in HER2 positive disease? Well, so in the interest of time, I didn't include the phase 2 data, but so when first we saw activity of immunotherapy in HER2 negative disease, we already at MSK had preclinical data to support use of dual anti-PD-1 and HER2 therapy from biopsies and so forth. So I designed a phase 2 study in just single center, 37 patients with combination of pembrolizumab plus trastuzumab and chemotherapy. And what we saw is a double of overall response rate and survival. So with TOGA, the overall response rate was 47%. We saw 91% overall response rate and over 2-year median overall survival in that study. And after we published it, almost simultaneously, the Korean group finished phase 2 in South Korea that showed very similar results. So that's unusual to have East and West data replicated so well. So with that, we, even before the phase 2 finished, and it's interesting, in the phase 2, PD-L1 was not a predictor. In fact, PD-L1 negative patients did a little better than PD-L1 positive patients. And again, highlighting the importance that PD-L1 overexpression may be a mechanism of trastuzumab resistance. So that's the primer. So we took this to KEYNOTE-811, and the key criteria were just having HER2-positive disease. PD-L1 was not a selection criteria, so patients with IHC3+ or IHC2+ FISH-positive tumors, irrespective of PD-L1 status, were allowed on the study. These were all adenocarcinoma patients. 692 patients were treated. This was a blinded study, placebo-controlled, and the comparator arm had pembrolizumab, trastuzumab with oxaliplatin and capecitabine. I do think the choice of platinum matters, and so oxaliplatin clinically is well tolerated, and it may induce dendritic cell presentation more so than cisplatin. So we used placebo and trastuzumab for the comparator arm. And what we were able to demonstrate is that although we saw 91% overall response rate in phase 2, we saw 74% overall response rate in phase 3. And because we were expecting high response rate, we used it as first interim analysis. And so the first interim analysis was positive, and based on that, the FDA approved this combination, and it's part of their standard practice in the United States for first-line therapy. The overall response rate of difference of 23% we have not seen before in a phase 3 study. We're hoping that's going to translate to survival benefit. The data has not yet matured, but it will be presented shortly. But we also saw that a combination of dual anti-PD-1 and anti-HER2 therapy increased the depth of response. So the greater than 80% reduction in tumor measures was seen in more than 30% of patients, double than what we saw in standard of care arm. And the regimen was well tolerated. So the question about PD-L1 comes up, and what's interesting is that over 85% of patients in this cohort had high PD-L1 overexpressing tumors, CPS 1 or greater. And so because the low PD-L1 tumors are so rare, there was only 21 patients. The confidence intervals are so wide. But this highlights, and based on the phase 2 data from both America and South Korea, and this phase 3 data, that PD-L1 is likely not a predictor. We have high responses, and we're waiting for the survival data. Particularly because this regimen was so well tolerated, the AEs were pretty much equivalent across the grade 3-4 AEs between the two groups. There was slightly higher rate of immune-related adverse events, but they were relatively well tolerated and minor. These were some of the other trials that are, so the Integra study was already presented and published. We have, some of the other trials that were open, but now are having to, reconsider what their primary endpoints are and the updates. So we talked about early, first-line disease. Now let's talk about acquired resistance. What happens? Well, I showed you the data that showed that co-occurring alterations happen in first-line setting, right, and that drive primary resistance. And unfortunately, the longer you wait, the more of secondary alterations that the tumor gains. So it becomes noisier. More EGFR, more RAS amplifications, mutations, PI3 kinase, MET, and so forth. But one of the most important factors, and we showed this already in 2018, is that after progression on trastuzumab, what the outgrowth of the HER2 negative clone drives the resistance. So the tumor loses HER2. This was a patient that I saw in the clinic. He was actually consented to go on one of my HER2 positive second line studies. And before going on the study, we did a biopsy of the progressing liver lesion, and the tumor lost HER2. It was HER2 negative. So we ended up treating him with paclitaxel ramucirumab off trial because he was not eligible. So it's very important. One of the key factors about HER2-positive disease or any biomarker-selected population, if you're going to target the biomarker, make sure you still have it. You can't go into the battle with outdated map. So what about second-line studies? What was the consensus on it? Well, I gave you some of the foreshadowing. Just targeting HER2 again in a way that we've targeted in breast does not always work. The Gatsby study looked at TDM1 against paclitaxel, which is an active regimen in gastric. It was not even including ramucirumab, so it was, should have been an easy regimen to beat, but it didn't. There was no survival benefit. It was not inferior, but this was not an inferiority. It was a superiority study, so it was a negative study. So TDM1 did not change practice, could not do better than paclitaxel. Trastuzumab deruxtecan, obviously, it's a good year for TDXT with all the breast cancer data and the plenary session at ASCO. It was really groundbreaking work. So what we know about TDXT is it's a high-potency payload that has a irinotecan, a topotecan-like drug, so it's not a taxane. Irinotecan works very well in gastric cancer. It has a high drug-to-antibody ratio, and it's a humanized antibody that binds to the receptor, gets internalized, and then dissociated within the cell and kills the cell from within. Because it has such a high drug-to-antibody ratio, unlike TDM1, in preclinical models, it looks like it has a lot more bystander effect than other ADCs. Here you have the HER2-positive NCIN87 cell in the control and the HER2-negative MDAMB468 model. And so when you look at the TDM1, there was very little bystander effect. With TDXT, both HER2-positive and HER2-negative cells are impacted with a dramatic tumor regression. And I think, data clinically suggests that this is the reason why TDXT succeeded in gastric cancer while other HER2-directed agents in second line failed. Destiny Gastric 01 was the first study that showed activity in this disease. It was a study primarily done outside of Europe. It was mostly Asian study in South Korea, Taiwan, and Japan. And there were cohorts that looked at HER2-positive tumors and exploratory cohort that looked at HER2-negative tumor, and I want to show you both of the data today. So TDXT dosing is higher in gastric at 6.4 mg per kg, so it's higher than breast, and that's been sort of a trend in gastric with trastuzumab also and ramucirumab, that we see that PKs in gastric can be trickier, and maybe the tumor burden or other metabolism factors that sometimes to reach the same PK, a little higher dose is needed. And the patients were randomized against physician's choice treatment. These were heavily pretreated patients. In Japan, paclitaxel or ramucirumab is given routinely, so they've already had taxanes. So it was either irinotecan or taxane as physician's choice. And then for exploratory cohorts, patients were used IHC2+, FISH negative, or HC1+. The other interesting part about the study, they did not mandate biopsies at trastuzumab progression, right? Because this was third-line patients. There was nothing else for them to get. But they confirmed HER2 positivity centrally based on archival sample. So HER2 positivity was confirmed at some point during the patient's course, but not necessarily at the time of trastuzumab resistance. And that's an interesting point that you should remember. The overall response rate, so remember with paclitaxel ramucirumab in second-line setting in gastric, overall response rate is about 25%, right? Here they got in third line, it's a Japanese and mostly Asian study, so patients tend to do better in general, but still 42%, that's pretty good. It was good enough to get into New England Journal of Medicine, if it means anything. So versus 12% overall response rate. So in third line setting, that's what we see. 12% is actually pretty good. In America, you probably see a lot less. And what's really important is the median OS of 12.5 months. Again, this is Asian cohort of patients. They tend to do better, but still, that's the survival curve separation is very impressive. So based on this, the FDA actually was so excited about it, they approved Trastuzumab deruxtecan in America in second-line setting after Trastuzumab failure. So you don't have to wait till third line. There's a huge attrition, right? In America, we see that only about 40% of patients get to second line. So if you wait to third line, you're going to lose most patients. So, it was a little bit of a bold choice and made clinical trial development actually difficult because, obviously if you have a standard of care in second line, that's what patients want is HER2-directed therapy in second line. But it's very patient-centric decision. I understand that. What about cohort 1 and 2, the exploratory cohorts? So the HER2 low, and you'll hear from Elena about the HER2 low colon, but here we have 36.8% IHC 2+ in ISH negative, tiny numbers, 19 patients, but it's interesting, and 19%, only 4 patients responded in IHC 1 cohort. But if you think about it, if the response rate otherwise in third or fourth line setting is less than 10%, that's not bad. And these are the waterfalls. So, what about the U.S. and the Western population? In parallel, even once the FDA approved the study, the use, we had a phase 2 single-arm study, and this was a Western population study. It was mandated to be second-line patients, and we mandated a biopsy at trastuzumab progression, right? Slightly different patient populations because since it's a US and a Europe study, these are mostly G-junction tumors where, again, there's more co-occurring alterations, there's more RAS amplification and so forth, so noisier tumor. While in gastric, in Asia, it's mostly distal gastric cancers. This was a very well done study. It was important for the company to do it that way because getting everyone to get a biopsy before going on the treatment was a paradigm shift in gastric cancer. Although it's done routinely in lung, it's not something that was done before. 6.4 mg per kg once again, and confirmed overall response rate is 38%. So, some people would say, well, it's a second-line study and you confirmed HER2, wouldn't you expect a higher response rate? Yes and no, because G-junction tumors have these co-occurring alterations. And imagine, just by making it to third line, you already declare yourself as slightly better tumor biology and maybe more addicted to HER2. And in second line, the heterogeneity factor still exists. So these are sort of the waterfall plots side to side. The median OS for Destiny Gastric 02 was not yet presented, but it did meet its primary endpoint, which was based on efficacy, based on overall response rate. Median PFS actually looks identical, 5.5 months, 5.6 months, highlighting the biology of the disease in US is trickier and it's harder to do, which, again, points to the fact that if we wait till second or third line setting, it's harder to help our patients. I think targeting HER2 most effectively and with combination therapy in first line is probably the best way to get patients to do well. The side effect adverse events profile with T-DXd in second or third line is slightly different, also Asia versus the West. In Asia, this was at later line therapy trial, so they were more heavily pretreated, right? So the bone marrow suppression, platelet count, anemia, and neutropenia was more of a factor. In US, in my experience using this drug, and I've been using it for several years now, there's more GI toxicity, more nausea, vomiting, more LFT abnormalities. Bone marrow is not as big of a factor because we use it in earlier line. What patients and clinicians need to understand, this is chemotherapy. It's not immunotherapy. I think people expect it to be a designer drug that they're going to feel great about, and they feel like chemotherapy patients. Interstitial lung disease is not as big of a factor in GI tumors as it was in lung or breast. The ILD risk is probably in the single digits or like 7 to 10%, depending on which cohort you look at. Most of the time, if you stop at grade 1 or 2, right, asymptomatic, just radiographic findings, it's not a problem. very few. So on Destiny Gastric 01, there was no grade 5 events. Destiny Gastric 02, there was 1 grade 5 event. So close monitoring, and what I tell my fellows and junior faculty is look at the scan yourself, read the whole report, not just the impression, because these small findings of ground glass opacifications, the radiologist may not realize that they're important, right? Because they're minor and they're not disease, so they may not even put it in the final impression. But the GGOs, ground glass opacification in patient on T-DXd can be very serious findings. So just look at the scans yourself. So what about the definitive study? How do we get this drug in? So in Japan, it's only approved in third line. In Europe, you don't have it yet. And that's the reason, why Destiny Gastric 04 actually helped write this study. And it was going to open in the US, and then the FDA approved it in the US. So we can't even, we don't need it in the US. So the FDA is very enthusiastic and it's good, but it makes sometimes having definitive trials a little harder to do. So T-DXd was randomized in the study against standard of care, which is paclitaxel or ramucirumab, right? And the study is ongoing. I think it's an important study. So if it's open near you, I think, some centers struggle with it because a biopsy at confirmation is important. Destiny Gastric 03, for those of you who saw my talk yesterday, I'll give you a brief again, repeat. So Destiny Gastric 03 is a study that we designed and opened a while ago. Now we have over 200 patients enrolled. The purpose of it was to, capecitabine or 5-FU is the cornerstone of all GI tumors, right? So if we were to take this regimen to first line, it's important to be able to show efficacy and safety with capecitabine. So we created these different cohorts. We're focused now on first-line cohort with capecitabine and T-DXd combination, and based on Keynote 811 data, also in combination with immunotherapy, with pembrolizumab or davrolumab. And what we saw is, we know from previous experience that patients who have heterogeneous tumors don't do as well. And so for the Destiny Gastric 03, we did not mandate central confirmation of HER2 before patients went on to receive therapy, but everybody needed to have HER2 testing after they went on centrally. And so it's only 44 patients, the initial biomarker assessment. What we saw again, there's about 20% discordance rate between central and local HER2 testing, highlighting the importance of central testing for large phase 3 studies. I do believe that because those 20, or you have to enough power to assume that these 20% will be negative or discordant, and those patients won't do as well and will dilute your delta, right? What we also found is that tumors that have IHC2 plus FISH-positive tumors are the most likely to be discordant because of the focal positivity. Furthermore, as expected, not surprising, but very high percent of HER2-positive tumors in first-line setting are PD-L1 positive. CPS 1 or higher was seen in 85% of the population, further supporting the use of dual combination in this setting, and again, suggesting that it's likely a mechanism of intrinsic resistance. So with that, in the United States, we have pembrolizumab plus trastuzumab as an approved regimen. Most people and most patients actually started to request it after the phase 2 data came out because it was published in Lancet Oncology and everyone knew about it. So it was very actually hard to accrue even to the phase 3. It's a relatively easy regimen to give, and immunotherapy is available for HER2-negative disease, so it's now available for HER2-positive disease as well. Trastuzumab deruxtecan is used after trastuzumab failure unless the patient has a clinical trial option. It's very difficult to now randomize to non-HER2 directed therapies if you have a comparator arm. So most trials like that struggle in the United States and don't accrue well. We do biopsy with before the patient goes on to second-line therapy, and if the tumor is HER2-negative, circulating tumor DNA is an option as well to check. But if the tumor is HER2-negative, use of T-DXd in second-line setting is not recommended. So the summary is, immunotherapy is now available in first line, both for HER2 negative and now HER2 positive disease. Pembrolizumab, trastuzumab with chemotherapy is hopefully will become a standard once we see the survival data for worldwide. Because immunotherapy is used so routinely in first-line setting already, it's been accepted in the United States. For HER2-positive disease, use, and again, we didn't have a chance to talk about it, but maybe we can talk about it in case discussion. Circulating tumor DNA is helpful to assess. What we see from our trials is that if you have high level of ERBB2 amplification in the plasma, those patients tend to do more to do better with progression-free survival and overall survival. And loss of HER2 can be assessed only in patients who are truly ctDNA secretors. So if you have a patient that you didn't check baseline ctDNA and then you checked it at cycle 6 of therapy and they're ctDNA negative, it's not helpful because you don't know if they ever had the ctDNA, right? So don't do that. But for MSI tumors and HER2 tumors, I do like to use ctDNA as a mechanism of understanding where is the resistance, how likely is the patient to have durable response. What we see from our data at MSK is that if they clear ctDNA at 3 or 6 weeks, or even a little later, they're going to be okay, probably for over a year, 2 years on first-line therapy. If they don't, you have to plan ahead. It's not going to go well, and you have to think about what to do next. I do still biopsy, even if ctDNA does not show ERBB2, because sometimes there's just not enough amplification to show it in the plasma, and sometimes we get HER2 positivity in the tumor then. If they're HER2 positive in second-line setting, trastuzumab deruxtecan is the preferred approach. But I mentioned to you that now we have Destiny Gastric 03, which is what we use in first-line setting. It's trastuzumab deruxtecan with capecitabine or 5-FU and pembrolizumab. So if you have that study open, please help us to finish it, girl. It's almost done. So this is a case discussion that we brought to you. This is a 70-year-old patient who was diagnosed with stage 4 gastric adenocarcinoma. She presented with disease in her lungs. She has good support network and remains active and independent. Functional status is excellent of 1. On biopsy, you hit the jackpot. She's HER2 positive, and also has high level of PD-L1 overexpression by CPS of 20. So what would you do for this patient? Would you recommend frontline therapy with chemotherapy plus trastuzumab? Would you do something else? Or would you give her pembrolizumab, chemotherapy, and trastuzumab together? So hopefully you said pembro-tras. I mean, if it's not available in your area, hopefully it'll be coming soon. So I guess the other question, and it's a little bit of a trickier question, what would you do in the same case if the tumor was PD-L1 negative, HER2 positive, PD-L1 negative? Do you think, in this case, it's inappropriate to use pembrolizumab? What we see from the phase 2 data and other data preclinically is that what drives the benefit here is the HER2. You're augmenting the HER2 anti-tumor response in ADCC of trastuzumab with pembrolizumab. So it's not about CPS per se, it's about HER2. And so in my experience, the depth of response and the duration of response is much better if you add Traz plus Pembro together. So she's done well for a long time. I guess we didn't indicate it, but let's say she was on therapy for 2.5 years. And we have patients on the initial phase 2 that are still cured, and I started that in 2016. So these patients sometimes are harder to take care of because they get so, they forget they have stage 4 disease, and their expectations are quite high. So unfortunately, Madeline progressed and she's now feeling okay, but not great. She's having some cancer-related symptoms. And you convince her to have another biopsy. Let's say she has a liver metastasis. So you biopsy, and luckily her tumor is still HER2 positive. So, her functional status is she's feeling tired, but she's still functional. What would you give her? Would you consider trastuzumab deruxtecan in second-line setting? put her on a clinical trial, perhaps, or other options. So in our practice, we do have TDXD and clinical in standard practice. And again, if you wait till third line, these patients become frailer, and it's harder to get them through treatment for bone marrow suppressions, but other clinical factors as well. So the practical points on safety and efficacy. So first line, Keynote 811 regimen is pretty well tolerated. I would say practically it's a little tricky sometimes, and I'm sure you see this with FOLFOX and nivolumab as well. If they bump their liver function tests a little bit, or they have minor diarrhea, it's hard to understand certainly whether or not this is immune-related or if they're just have mild LFT abnormality from oxaliplatin. What I would do practically is just hold the treatment and recheck the labs in 3 days. If the LFTs are already better, it's not immunotherapy, right? So immunotherapy, immune-related transaminitis does not fluctuate like that. So it never is. Remember, this is stage 4 disease. Do no harm. So just hold the therapy, and if they're getting better, you can probably resume everything together. If the LFTs are continuing to climb up, I would start Solumedrol or steroids at 1 mg per kg, because it's probably, if it's grade 2 or 3, it's probably immune-related. Other practical points, immune-related endocrinopathies you can treat through, so hypothyroidism, even diabetes, if it's well controlled, you can just replete thyroid Synthroid or give them insulin and continue to treat. Adrenal insufficiency, although it's very rare with immunotherapy and is mostly related with ipilimumab, I do see it with this regimen, adrenal insufficiency. And so if your patient is all of a sudden very tired, can't get out of bed, check early AM cortisol and ACTH, and that's a very easy way to know if they're adrenal insufficient. With Trastuzumab deruxtecan, the factors, the major thing you have to watch out for is interstitial lung disease. The exact mechanism of ILD is not yet known. We don't know the factors that make people more likely to get it. In gastric cancer, in our experience, and the data in lung and breast suggests that the earlier lines of therapy, the ILD risk is lower. I think that's part of the reason in if you monitor grade 1, 2 ILD on scans and you're able to use these drugs, you can get the patient through safely. Monitoring and managing nausea is a factor in our patients. I find in the United States, at least, the rate of grade 3 nausea is what makes people, uncomfortable, and so giving them delayed emesis regimen, Imen, Decadron often, fixes it, and they do okay. And with that, it's a pleasure to introduce Dr. Eliz to talk to us about colorectal cancer, HER2. Thanks.
Thank you, Dr. Janjigi, an excellent presentation. Later on, we will have some time to address your questions. So I have to say that in colorectal cancer, we don't have that amount of data that you have in gastric cancer, so the situation is worse. But even if worse, the situation of precision medicine metastatic colorectal cancer. But we are trying at least, and we will try. We'll try during the presentation to go through this particular area, metastatic colorectal cancer. So we know the interplay that have the EGFR receptors and the fundamental hallmark that represents proliferation in the surveillance of metastatic colorectal cancer. And particularly, it's important to stress that the HER2 protein has no ligand. This is interesting, and not everybody knows about that. But it's the preferred dimerization partner for the other HER2 family receptors, and that is particularly important in colorectal cancers. When we have also in colorectal cancer a HER2 amplification, we have a downstream signaling of the MAP kinase pathway, and then we have a sustained proliferation and finally survival of the cancer cell. So, about HER2 in colorectal cancer, we know that it's not a prevalent alteration. Less than 5% of our patients will have a HER2 overexpression. We know that this molecular aberration is enriched in RAS wild-type tumors, and it has not been described differences between sex, something that, for example, is different for the BRAF-mutated colorectal cancer, that it's more prevalent in women. It's more common also in left-sided colorectal cancer, and it has been also described that these tumors used to present a particular pattern of metastasization, and commonly we can see in these patients brain metastases. The role of HER2 in colorectal cancer as a biomarker, it has been described, it's controversial regarding the prognosis effect. It has been pointed out that it could be a bad prognosis factor, and regarding its role as a predictor of response to anti-EGFR therapy, that's also really controversial because we had some data about the lack of efficacy of anti-EGFR treatments in this particular population, but we have also data coming from the CALGB trial in which what we see is that patients that indeed had a HER2 overexpression did obtain a higher benefit of anti-EGFR treatment. So at this time point, this is one of the questions that indeed we have received from the virtual audience about if we need to avoid the anti-EGFR treatment in metastatic colorectal cancer with a HER2 overexpression. We could say that probably not, and indeed there's no guideline that recommends to avoid the anti-EGFR treatment in this particular population. Also, a particularity in colorectal cancer is how we determine the HER2 overexpression is quite different from the breast cancer and gastric cancer. And indeed, the Heracles criteria has been described and have been included in the guidelines for our pathologists to do the test. And as you can see here, is quite different. And what the main difference probably is the threshold of the cutoff of the HER2 overexpression, that it's particular in the case of colorectal cancer. So again, it's a difficult illness to treat, first because it's not widely adopted, the determination of the HER2 status in the frontline setting. As I mentioned before, it has been included in the NCC guidelines, but for example, the ESMO guidelines do not include still the determination of HER2. And as I mentioned, the particularity of how to address this particular tumor and the available targeted therapy for this tumor, it's also it's not clear, and the equity is also different depending on the areas and the country. Another thing is the role of HER2 mutations in metastatic colorectal cancer. Also in this case, we don't have a clear idea about its role, neither the prognostic effect or the predictive effect, not only regarding the anti-EGFR therapy, but also the HER2 targeted therapy. So, regarding the HER2 testing, when and how to determine this molecular aberration, here you can see a screenshot of the NCCN guidelines in which upon the diagnosis of metastatic disease, the recommendation is to test the HER2 amplification, but it is not included in the ESMO guidelines. It is true that it has been published the SCAT scale, the ESMO SCAT scale, in which the HER2 is considered a biomarker of level 2 for metastatic colorectal cancer, because of the implications that would have to select these patients to be recruited in clinical trials. But as I mentioned before, in Europe, we still don't have an approval for targeted therapies, and the role that these targeted therapies play in the therapeutic armamentarium of metastatic colorectal cancer is not well established. So here is about the how. How are we going to determine the HER2 overexpression? As I mentioned before, the HER2 positivity in metastatic colorectal cancer is quite different from other solid tumors like breast and gastric cancer, and now has been adopted the Heracles criteria that indeed was already validated in more than 1,000 patients. And here we have a scale with a staining from 0 to 3. And again, the importance here is the threshold used for the cutoff and the definition of HER2 positive or negative. So about the therapeutic aims, you know that we have several clinical trials and drugs that have been evaluated in metastatic colorectal cancer. Again, is an important limitation, the lack of the knowledge of this biomarker from the very beginning, from the frontline setting. And this is important because if we believe the data about the potential bad prognosis of this molecular aberration in metastatic colorectal cancer, if we wait to do determination in the second line or in the refractory setting, we may lose some patients that could have a benefit to be included in this particular clinical trials. So it is very well known the results of the Heracles trial evaluating trastuzumab, lapatinib, also my pathway trial in this case with the combination of trastuzumab, pertuzumab, also promising results and impressive results from the Mountaineer trial, in this case with combination of tucatinib, or the Triumph trial that evaluated the combination of trastuzumab and pertuzumab. Here in this slide, and I'm not going through all of these clinical trials because we are here today to focus about new drugs in this particular tumor. Here you can see that the inclusion criteria may differ for some clinical trials. In the majority of cases, the population was restricted to KRAS and NRAS wild-type tumors. In some cases, it was required for the patients to have a tumor BRAF wild-type, and also the criteria for the diagnosis may have some variations depending on the clinical trials. But it's important to stress that the Destiny CRC01 trial evaluating trastuzumab deruxtecan had two cohorts, as it was mentioned before, for those patients who were HER2 low, as we will see later on. And the difference in this case is that we did not find any type of efficacy for these patients, but the patients that were truly HER2 overexpressed. So trastuzumab deruxtecan has been excellently described before. It's a novel therapy. It's a humanized anti-HER2 monoclonal antibody that has a particular feature, and it's a payload ratio that is higher, and that makes easier for the drug to be to arrive to the tumor. Just say that. So maybe that's why in colorectal cancer we may observe a higher activity of this particular drug, and it represents also a paradigm change in what we expect from developmental therapeutics. So here you can see the study design of the CRC01 Destiny trial focused on metastatic colorectal cancer. These patients need to be diagnosed of an advanced metastatic colorectal adenocarcinoma. It was required a central confirmation of the HER2 overexpression by the Heracles criteria. These patients need to be RAS and BRAF wild type, and they must not previously receive more than 2 prior regimens of therapy. So these are not heavily pretreated population, and that's why it's important, as I mentioned before, to have the status of HER2 from the very beginning, because once the patient is progressing, you are prepared to offer in a rapid way an option for these patients, particularly in these clinical trials in which a central confirmation is required regarding the biomarker to be included in the study. So also it's important to note that these patients could have previously been treated with an anti-HER2 therapy, and this is also quite important, and again, the relevance of the higher payload of this particular drug. And at the time point that this trial was developed, we had also data coming from the gastric cancer studies, and those patients who have history of interstitial lung disease, or it was suspected interstitial lung disease, were excluded from the study. So as I mentioned before, we have 3 cohorts in this study. Cohort A for those patients who were truly HER2 overexpressed metastatic colorectal cancer patients, and then we had other 2 cohorts, B and C, for the type of HER2 low metastatic colorectal cancer. The primary endpoint was confirmed overall response rate. So here you can see the features of the patients, more or less well balanced between the different cohorts. So although it is true that we have just 15 patients and 19 patients in cohorts B and C, you can see that 75.5% of patients were HER2 overexpressed, that are the patients that were included in cohort 8, and 100% of the patients were previously treated with 1 or 2 lines of chemotherapy. Here you can see the results in terms of efficacy and response rate. you can see that in our case, previously Dr. Janjian discussed about a small proportion of patients that did present a response rate being HER2 negative, but in this case, we saw a 0% of response rates in our patients that did not have HER2 2+ or 1+. So in this case, the behavior is really different from other tumor types, of course, very different from the breast cancer scenario, but also different from the gastric scenario. In this case, we see no activity for these patients. In the case for the truly HER2 overexpressed metastatic colorectal cancer, we saw excellent responses, particularly in refractory metastatic colorectal cancer with a 45.3% and a disease control rate of 83%. Here you can see the representation of the forest plot, and you can see the majority of the patients do obtain a benefit, either in terms of response rate or stable disease. And if we take a look to the subgroup analysis, we can see how the patients that do obtain a benefit with this drug are the patients who had a tumor with a HER2 overexpression. But again, important to say that these patients were patients that, in case they would have been treated with a targeted therapy, were allowed, in focus on HER2, were allowed to be included in a clinical trial, and that's a particularity. In terms of progression-free survival and overall survival, again, the benefit is confirmed for HER2 overexpressed tumors with a median PFS of 6.9 months, but it is huge in the scenario of metastatic colorectal cancer, and 15.5 months for those patients in terms of overall survival. If we consider other particular populations that also patients who present low-frequency molecular aberrations, like the case of BRAF-mutated tumors, more or less a similar population, because these patients, when they were included in the Beacon trial, were patients that could be treated in the second or in the third line, patients with bad prognosis. And indeed, the results in terms of overall survival and progression-free survival, treating them with targeted therapy, it's not such as we are observing here. So that's why the key message is that the role of HER2 as a biomarker is crucial. And from my point of view, the sooner we have the information, the better for the patient, because we can be ready to offer a targeted therapy, although in the scenario of a clinical trial, or maybe if accessibility, a recommended treatment for them. So in terms of safety, it has been also presented before, no differences compared with other tumor types. It's important to see that the pneumonitis and the interstitial lung disease was also observed in the DESTINY-CRC01 colorectal cancer trial, in which what we see is that 8 patients presented this adverse event. In 3 cases, the event was fatal, and we can see that the median time from the appearance, it depends. It's really different between the different patients. So it is really important to consider that this is an adverse event that can happen. It's important to monitor these patients along the treatment, and once we identify this potential treatment combination, start as soon as possible treatment with corticosteroids. So also, like in the case of gastric cancer, the dose of Trastuzumab deruxtecan that was used in the CRC01 colorectal cancer trial was 6.5 mg/kg. In the case of the DESTINY-CRC02 trial that now is recruiting, it's important to stress here several differences. First, patients whose tumor harbor a RAS mutation are allowed to be included in the clinical trial. Also, in this case, what the study is going to compare is 2 arms. Arm 1, 5.4 mg/kg, and arm 2, the dose that was used in the DESTINY-CRC01 clinical trial, with the primary objective of assess the efficacy of these 2 doses, being the primary endpoint that confirmed overall response rate, this study is recruiting, and for sure these results will be very interesting to see, particularly for those patients whose tumor harbors a RAS mutation, that it is not common in colorectal cancer. The majority of the patients with a HER2 overexpression will have a RAS wild-type tumor, but now that we are starting to perform this NGS testing from the very beginning, and we have the possibility to have the information of this biomarker, sometimes we can see this coexistence, and it's important to assess also the efficacy of the treatment in these particular tumor types. So regarding the role of HER2 in other GI malignancies, we have evidence from other solid tumors like biliary tract tumors, or for example other clinical trials that are recruiting for all solid tumors, type of basket trials in which the inclusion criteria is the HER2 overexpression. And we have very nice data coming from some studies like the MyPathway study, for example, the trials testing Trastuzumab and Fanidatamab that are new compounds. The first one that includes an FC portion that generates ADCC, and the second one that has two different links to the HER2 receptor, and maybe can increase the efficacy of this particular treatment. So very promising the area of this particular solid tumors. So let's move to a clinical case. This is a clinical case of our outpatient. This is a 60-year-old female with no relevant past medical history, and this patient started in December of 2018 with asthenia and weight loss. The study was initiated, and it was performed an endoscopy that showed a low-grade sigmoid adenocarcinoma. The CT scan, what showed was the confirmation of a sigmoid tumor with liver metastasis from the very beginning. And in the PET scan, because it was considered just to assess the potential of resecability for this patient, showed a possible bone lesion at L4 that was strange for us, considering that we didn't observe any other metastatic localization apart from the liver, and we decided to perform a biopsy that did not show tumor involvement in this particular situation. So we decided to give the chance to the patient, and we consider this patient a stage 4 sigmoid adenocarcinoma with liver involvement. So we performed the molecular biology testing, and what we see is that exons 2, 3, and 4 of both KRAS and NRAS were wild type, also exon 15 of BRAF was wild type, and this was an MSS tumor. So after discussing this case in the MTD, the first treatment option for that patient was frontline setting with FOLFOX in combination with panitumumab that she started in January of 2019. After 4 cycles of treatment, this patient presented a partial response. Also, she obtained a rapid clinical benefit with the treatment. And after 10 cycles, we observed a confirmed partial response, and that's why we repeat a PET scan considering the possibility to go for a surgery. You remember that we obtained a tumor biopsy of this bone lesion that was negative, but here you can see that we did not observe any alteration in the next PET scan. So it is really suspicious, but again, sometimes this is a real case, and sometimes in the clinics we need to take decisions, and we decide to give the chance and the option to the patient, and finally we decided to go for a surgery. First, the primary tumor was surgically removed, one tumor, and then later on she went for the liver surgery, in which all the disease could be resected. And after that, the patient had some complications with the treatment, and we follow up her. You remember that the total of cycles received was 10 cycles of FOLFOX in combination with panitumumab. Okay, so just as a reminder, the surgery was in December of 2019. And then in May 2020, so 5 months after, we diagnosed a recurrence of the illness. It was a recurrence with high tumor burden, with liver, peritoneal, and bone involvement. So it seemed that that bone lesion was true. And we started at that moment FOLFIRI in combination with bevacizumab. After 5 cycles, unfortunately, the patient presented progression disease, and the first Treatment that she received in that setting was radiotherapy. She presented with pain at that location, and we decided to go for an NGS testing to screen the possibility to offer the patient an inclusion in a phase 1 clinical trial. Maybe here you can say, okay, you may have a suspicion about the HER2 status of this patient, but remember that the patient had an excellent response indeed to FOLFOX-panitumumab. So not always it's easy to have a suspicion about the potential HER2 status of the patient. So the fact that a patient responds to anti-EGFR therapy does not necessarily mean that the fact that a patient has a HER2 overexpression does not necessarily mean that these patients are not going to respond to a combination of chemotherapy plus anti-EGFR agent. As I mentioned before, that was the conclusion of the CALGB study when assessing the efficacy based on the HER2 status. So what happened with the patient? We performed the NGS testing, and we performed the test both in the primary tumor but also in the liver sample of 2019, and we found a HER2 overexpression by immunohistochemistry. The NGS testing, we perform an NGS testing in FFPE at the HIO that includes 450 genes. At that time point, we had the option also to perform a liquid biopsy in the context of a research project, and we found a mutation in TP53 and also APC, very common in colorectal cancer. Mainly 90% of the tumors will harbor these mutations, a beta mutation. We also observed in liquid biopsy the HER2 amplification and also the confirmation that this was an MSS tumor. So here the patient had the option to be included in a clinical trial with a dual HER2 blockade. After 3 cycles of treatment with an excellent tolerance, the patient improved in terms of clinical benefit, and also the radiological assessment showed a partial response, although after 6 cycles, so a total of 6 cycles of treatment, she presented a progression of the disease. So from this clinical case, I wonder what would have happened if we have incorporated the HER2-directed treatment before in the medical history of this patient. It is true that we may have suspect this situation because of the evolution of the patient, but not always is obvious and not always is easy, and that's why, from my point of view, it's important to perform the test from the very beginning. So these are the take-home messages from this case. So for this particular patient, as I mentioned before, earlier HER2 testing would have been optimal. I think so, because we did also had at that time point clinical trials for this patient in earlier lines of treatment. The early confirmation of HER2 amplification would have support so the earlier use of HER2-directed therapy, and clinical trials testing trastuzumab or trastuzumab deruxtecan-based option could have been considered, allowing for earlier use of HER2 therapy. Or, for example, in this particular patient that was treated with a targeted therapy, an inclusion in clinical trials in which the drug may have or may overcome the resistance for this patient would also have been an interesting option. So, a summary and conclusions, I think that it's a proof of concept in not only in colorectal cancer, but it also in tumors that a better knowledge of the underlying biology of the tumors has led us to move to the drug into the undruggable. Also, in the case of colorectal cancer and like the BRAF and KRAS paradigm, however, the best treatment strategies and combinations for each tumor type must be considered in the histological molecular context, and HER2 represents a novel therapeutic paradigm in colorectal cancer. Evidence favors show the consideration of HER2 as a therapeutic target in metastatic colorectal cancer, and I would say also biomarker, and I think it's important, and indeed we have seen before data of the work that you are performing at your site, Jelena, about the drug development that must include other aspects such as pharmacodynamic assessment, biomarker analysis, and particularly in early phase studies, including dynamic designs to facilitate and accelerate the accessibility of more effective therapies for our patients. So now we have some minutes for some questions.
Great. So question number 1 is advancing gastric cancer options in PD-L1 positive and HER2 positive disease. So a patient is PD-L1 CPS 20 and HER2-positive IHC3+. But if you only have FOLFOX/nivo or first-line chemotherapy plus trastuzumab, so checkmate 649 or the TOGA, but not, pembro-traz, what would you do in terms of efficacy? That's a great question. I think this patient actually has a very high PD-L1 overexpressing tumor, right? Maybe a CPS 80. We don't know what the right answer is. I would say there's a subset of tumors, and I've seen a few in my practice, and I've anecdotally heard it from colleagues all over the world, that sometimes HER2 and MSI actually co-occurs. So a patient like this, just test for MSI, and obviously if the tumor is MSI high, I think immunotherapy would probably win. For HER2-positive tumor, my reflex is still to use trastuzumab, first-line therapy, and scan early, and maybe switch to immunotherapy. So for now, for HC3+, if you don't have immunotherapy in combination with trastuzumab, I would still use FOLFOX trastuzumab or CAPOX trastuzumab, unless it's an MSI tumor. And although it's very rare, but MSI and HER2 co-occurs. I actually just have a patient in my practice with EBV positive, HER2 positive tumor. So these rare instances do occur. It's very interesting and suggests interesting biology. Okay, another question. According to the data presented, not all advanced metastatic gastric G-junction adenocarcinoma patients are tested for HER2 status at diagnosis, at least in the United States. What are the major barriers to this testing? That's a great question. That's globally, it's a problem, right? Not everybody's tested for HER2. I think there's a factor of nihilism for gastric cancer. Historically, it's been a difficult disease to treat. Patients present and they're quite ill. They may not want any therapy. So that's probably one barrier, is a lack of knowledge. And also it's, if you're not treating disease often, you may not realize what you need to do. And two, I think some of this data may be data quality, because if the testing was done and then it came back later on a amended sample or a pathology report, it may not be captured. And three, sometimes, at least in other parts of the world, trastuzumab is not available. So as I mentioned, globally from checkmate 649, 40% of tumors were never HER2 tested locally, so that's probably because they didn't have access to trastuzumab. When titrating or treating patients with trastuzumab deruxtecan, how often do you scan patients for interstitial lung disease? So when we treat patients with TDXD, you don't have to scan any more often than what you would do for disease assessment, unless the patient is symptomatic or if they're having cough or any other issues. Every 2 to 3 months. Usually I, give them. So treatment is every 3 weeks, so I do either 2 or 3 cycles and do the first scan at 9 weeks. If there's a major response, you can do the next scan after 3 cycles more, and so forth. You don't need to scan or do x-rays or do anything else. We don't do PFTs in advance. None of that has been really shown to be helpful. Just talk to your patients, educate them. If they have symptoms, they have to report them. And if you see anything on a scan, usually you will see something before they develop symptoms. So regular, every 2 to 3 month scans is fine. So that was it. So do you this is a great question, do you use FLOT, pertuzumab, trastuzumab in HER2 positive early stage disease based on, the high path CR rate that was seen in clinical trials? In my experience when the clinical trial data suggests this pertuzumab, trastuzumab combination with FLOT is not an easy regimen, right? People have a lot of diarrhea and other factors. Ironically, path CR rate, we just saw a presentation yesterday, was actually not a predictor of outcomes, and nodal status is a better predictor. We from the US have a negative RTOG 1010 study of, as you know, carbotaxol, trastuzumab radiation, didn't show improvement in outcome. So I don't use pertuzumab, trastuzumab, or HER2 directed therapy in perioperative setting. I've had patients with borderline, really advanced tumors that you could say are not all that easily resectable that I've given pembrolizumab, trastuzumab to with excellent response. I think that regimen is well tolerated. Pertuzumab, trastuzumab, I don't use. We, of course, just finished accrual to FLOT plus durvalumab study. This was a Matterhorn study. So I think for these patients, you just have to put them on a clinical trial. How long would you keep a patient on trastuzumab? That's a great question. It comes up a lot. And if after newly diagnosed liver metastasis and gastrectomy. So I tend to not stop HER2-directed therapy until progression. I think some of these patients, I've had on for 5 years plus. Now that we have ctDNA, if you know the ctDNA was positive and they absolutely cleared it, and radiographically there's no evidence of disease, you could consider stopping it. We have changed the biology of this disease with these newer regimens. And occasionally, in very select population of patients, if there's a persistent primary left in place, but the metastatic disease is gone, and it's been years later, we do take out the primary. I think it improves progression-free survival and maybe overall survival. But in short answer, I don't stop. If they're doing well and their risk of cardiac toxicity is very low, just every time you scan the patient, do an echocardiogram as well to make sure their EF is not reducing. And just keep going. Okay, and this is a really good question. What is the future of HER2 PD-L1, HER2 PET scan? So we have a trial where we developed HER2 PET to look for heterogeneity of disease. Obviously, it gives you more of an advantage to be able to visualize the tumor and the metastasis at the same time instead of doing the biopsies. And what we saw in our trial, and we imaged probably close to 40 patients, is that more than half, 70%, 80% of them had some sort of heterogeneity in the uptake. In other words, if the primary tumor has very high uptake, SUV of 15, the metastasis, some of the metastasis are negative, some of the metastasis are positive. And actually, with Pembro-Trast study, we did it pretty regularly on patients, and the heterogeneity predicted the duration of benefit. So the lesions that were low PET scan uptake didn't do as well with HER2-directed therapy. I think it's a very useful tool in clinical trial development. It's not all that practical in the real world if you don't have a cyclotron and can't radiolabel trastuzumab on a regular basis, but it's a cool tool to image this heterogeneity. We've now developed a PD-L1 specific PET scan. So these functional imaging tools are very helpful to help understand the mechanisms of resistance and imaging.
Thank you. In the case of colorectal cancer, I think we have lots of questions, but I think we have just, we could make two groups. We have mainly two questions. The first one is the biomarkers that we should test in the frontline setting of metastatic colorectal cancer. We all agree about exons 2, 3, and 4 of KRAS and RAS exon 15 of BRAF. MSI, for sure, it's a biomarker that we need to test from the frontline setting. And about the role of HER2, my personal opinion is that, yes, we have to test the biomarker in order to better understand how that patient will behave. And the second question, indeed, was very related with this first question. In the case that you would have the result of the HER2 overexpression in the frontline setting and the patient has a KRAS and RAS BRAF wild-type tumor, are you going to avoid the anti-EGFR treatment strategy? In that case, the evidence that we have, it's not concordant. For some clinical trials, we don't see a benefit of adding anti-EGFR treatment to the chemo backbone. But the difference compared with other treatment strategies is that it's not harmful. It has not been described a detrimental effect of adding anti-EGFR therapy to patients that are HER2 with tumors HER2 overexpressed. But as I mentioned before, data coming from the CALGB trial that it was possible to evaluate the status of the HER2 overexpression in an important number of patients did not show these results. And indeed, those patients who had a HER2 overexpression seemed to offer additional additional benefit to being treated with an anti-EGFR treatment strategy. So it's not enough to avoid the anti-EGFR treatment. So go ahead, we can do that. Probably it's not harmful for the patients, and probably for some patients may be helpful indeed. So with this, Yelena, thank you so much. I think we all have learned a lot. It's incredible the data that you have in gastric cancer and the research project that you are conducting. Congratulations for all your work. Thank you to all of you for your attention, and thank you for all of you that you are connected virtually. So thank you so much, and enjoy the rest of the meeting.
Thank you so much.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/NEB860. This activity is supported by an educational grant from Daiichi Sankyo Incorporated.